So today we're going to talk about when to retire after a concussion, or concussions, plural. I think this is timely with Tua Tagovailoa having his, fourth concussion in the last 5 years, with Josh Allen being mismanaged a couple weeks ago. When do we call it quits? What does the evidence say? So this is going to be a deeper dive into this because it's not a quick and clean conversation. Hey there, I'm Dr. Mark. I've worked almost exclusively with concussion and post-concussion for the past 5 years, and in that time I've cleared over 500 athletes, from professional ice hockey players to NCAA swimmers to teachers to entrepreneurs to everyone in between. On this channel, we talk about concussion rehab, how to get over your symptoms, and how to get back to work, school, sport, or your regular life. So before we get rolling, as an example, per a systematic review of 93 studies, there are no absolute evidence-based reasons to retire an athlete from contact sports. And that is crazy, right? That's why we're going to dive into the nuance of concussion retirement and why it's not as clear-cut as many fans of contact sports would like it to be. This is literally a conversation and sort of a dance, not a clean algorithm. So first, let's review what we're talking about. Concussion. The injury itself. So a concussion is a functional and transient form of mild traumatic brain injury that results from acceleration and deceleration forces that get transmitted up to the skull. So in plain English, when your body or your head gets hit hard enough to shake your brain, it results in a functional and temporary form of traumatic brain injury. And we'll interchangeably call concussion mild traumatic brain injury. So MTBI, concussion, interchangeable. The symptoms typically fall into 3 categories, so physical, mental, and emotional. The physical or somatic symptoms include things like headache, dizziness, neck pain, nausea. The mental or cognitive symptoms include brain fog, difficulty remembering, difficulty concentrating, etc. The emotional or psychological symptoms include anxiety, depression, PTSD, irritability, etc. And then sleep. So insomnia will sometimes get lumped into physical symptoms depending on the list that you're looking at. But in about 70 to 80% of folks, 3 to 4 weeks is all it takes for this injury to be completely cleared. And in those 3 to 4 weeks, symptoms can go away in about 10 days. So that's pretty cool. But in another 20 to 30% of folks, these symptoms last longer than 30 days. And that's when you get PCS. So post-concussion syndrome, persistent concussion symptoms, persistent post-concussion symptoms. There's a bunch of different names for it, but when it lasts longer than 30 days, it's abnormal persistent concussion symptoms, PCS. When we have PCS, we need to look more deeply at the 5 symptom generators of concussion and post-concussion. We've got autonomic or physiologic dysfunction, we've got metabolic hormonal dysregulation, we've got visual or vestibular dysfunction, cervical spine dysfunction, and then this psychological trauma sort of overlap with all these symptoms. So many of the folks that fall into the 20 to 30% group who have PCS struggle because they run into doctors who continue to tell them to rest or don't know that they should or even how to evaluate for those 5 symptom generators. We could turn this into a 2-hour lecture on just this, like just concussion, but we'll cap it there for now. But think about this. If you're a young prospect or a professional athlete whose financial future depends on NIL agreements or playing contracts, so you're thinking thousands to millions of dollars, and there's no distinct rules of retirement, and you're not recovered, but you feel okay enough to play, maybe even medicated, you can see how this becomes a bit more complicated. Like, it could be enough money to change your family's financial situation or your life or your future trajectory, and you've got a little bit of a headache. Like, should you stop playing or not? It gets complicated. So what does the research find in general? So going back to that systematic review of 93 studies, not one single study in concussion research looks specifically at retirement. All the retirement data that we have, like even what I'm using right now for this video, is limited, consensus, very educated, but like common practice type data. Ultimately, concussion retirement is a really big educated guess between the athlete, their family, and their entire medical staff. So what was this systematic review looking at? They were looking at who's at risk for PCS and who's at risk for getting repeat concussions. So 2 really important factors, like what are the risk factors for post-concussion, like prolonged symptoms possibly impacting your life forever or a really long time. And then what are the factors that increase the risk of repeated concussions, which could increase PCS and so forth. So there were 4 risks for PCS that this study found. So the risk for post-concussion include the total symptoms at the initial visit, the time to initial evaluation, sleep disturbances after the injury, and symptom provocation on the vestibular oculomotor screening or the VOM. So total symptom burden at the initial visit, it's sort of intuitive that if you have a higher symptom load, there's a higher risk of PCS. Time to initial evaluation. So the later that you're evaluated by a concussion specialist, the higher your risk of PCS. So most data suggests that you want an evaluation within 4, no later than 7 days after your injury to kind of guarantee that classic textbook 21-day recovery. And once you get after about a week of assessment, you start to delay that recovery time. If there's sleep disturbances after the injury, so poor sleep, poor recovery, ask any new parents. Symptom provocation on the VOMs. So visual or vestibular deficits habits may indicate a more prolonged symptom experience. It doesn't always guarantee it, but it's a risk factor. So those are the 4 things that might risk PCS. Now let's look at the risk for repeat concussion, and there's actually not a big list. It is just having previous concussions. We don't specifically know why it is, so it's not an absolute contraindication to playing contact sports, but we do know that if you had a previous concussion, you're probably more likely to have another. There's this myth that 3 concussions means you need to retire. There is actually no set number of concussions that would indicate or warrant retirement, and we'll talk about why that is as we go down. So what are some of the possible factors we would want to consider before actually having this discussion of retirement? So these are the logical medical thoughts for why it may be unsafe for an athlete to return to contact sports. There's 6 things. We got persistent symptoms, so PCS, persistent abnormal physical exam, deficits on neuropsychological testing, and this could be even with removal from play and compliance with rehab, increased symptom severity or duration with repeat concussions. So when getting repeated concussions, they're more symptomatic and taking longer to recover. Concussions seem to be occurring with lower thresholds of impact, so softer or more innocuous hits are resulting in concussion. And then it's possible that we'll find throughout the rehab process structural abnormalities that may present risk with future head impacts. So maybe a vascular finding that future head impacts could put you at severe risk of a hemorrhage or something. So this seems sort of intuitive and can be summarized in 3 bullet points. If you have symptoms, abnormal exam findings, or deficits on computerized testing, maybe you're not ready to play. And some deeper factors there is, are these symptoms impairing your academic or your work performance? Have they lasted longer than 90 days, even with a super compliant multidisciplinary rehab plan? So that's bullet point 1. Bullet point 2, if you're getting concussed easier with less force, but more symptoms and longer recovery times, maybe you're not ready to play. Or maybe there's an incidental imaging finding through your recovery process that puts you at risk of future problems if head impacts continue. So it's estimated that we'll find incidental or coincidental imaging findings in about 10% of young athletes. Not all of these, because that's 1 in 10, that's a lot of people, not all of these are problematic to head impacts, but it's still more common than we maybe realize, and some of those some of those imaging findings are a risk for future head impacts, and that would be a possible reason to retire. But again, none of these are absolute, written in stone reasons to retire an athlete. So if none of those 3 bullet points above are really convincing, these are questions that we can add to the discussion for further deliberation and nuance and reflection as to, should I retire or should I keep playing? So we've got, is contact or collision an unavoidable part of the patient's sport? If you're just at risk of repeatedly concussing yourself, maybe we should pull back. Is there a theoretical risk of future concussion, prolonged post-concussion symptoms? Is that future theoretically acceptable? We've got examples like Daniel Carcillo, a very vocal advocate for the concussion, post-concussion CTE community, and he's been very vocal that these symptoms were not worth it. He's said multiple times that he would take his name off the Stanley Cup if it meant that he didn't have to deal with his symptom experience. And that's something to consider. Are you willing to balance future career aspirations with the potential risk of long-term cognitive impairment? And this gets into the conversation around chronic traumatic encephalopathy and CTE. Right now, the research is not as clear-cut as the mainstream media would want you to think. Right now, head impacts are an association with CTE, not a causation. Even though the jury's out, we still don't want repeat concussions. We still don't want, it's an association. We don't want to push you towards CTE. Is that something that's acceptable to you? How much is your identity enmeshed and entangled with being an athlete? We know that 15 to 20% of athletes undergo significant psychological stress when transitioning away from sports, especially when it's involuntary, like due to an injury. And going back to that CTE conversation, the living diagnosis, TES, traumatic encephalopathy syndrome, is heavily influenced by your mental emotional status. We find that TES criteria is dramatically influenced by things like anxiety, depression, and PTSD. Are there financial incentives and athletic goals that outweigh the benefits or risks? And this is one where people kind of turn their noses up and scoff at it, but be real. If you had a multi-million-dollar contract looking at you in the face, would you be willing to play an extra 16 games to get that money for your family, for your kids, for yourself? There's a lot of people that would say yes. I might even say yes. It's something to consider. And then, are there concerns or a family history of neurodegenerative disease? That's another thing that goes into the CTE conversation. Are you willing to live like this and decline in your life around your family, etc.? And these last points are more for people who really want to dive into this, athletes who are actively going through this conversation right now, healthcare practitioners watching this who haven't really explored this. We need to emphasize the importance of an involved multidisciplinary team, individualized assessments, including physical and psychosocial factors, the need to address coexisting conditions like mood disorders. Not everything is concussion. And then clear communication of the clinician's role and potential conflicts of interest. So team physicians who maybe have a financial incentive of keeping players healthy and on the field, field or people who have, money tied up in this product that's encouraging people to stay in treatment. It's important to be very open and transparent about your conflicts of interest. We need to emphasize, again, a collaborative approach involving parents, healthcare practitioners, and sort of everyone involved, especially for youth athletes. Ask the teachers, is this kid behaving as normal as they were before their concussion? Is academic performance slipping? Is social engagement slipping? The healthcare providers looking at all the physical exams, the parents looking at how they're at home. All this needs to be factored, particularly for young athletes. And then let's say retirement is kind of the direction we got to go. Encouragement to maintain healthy levels of physical activity post-retirement, and educating athletes about their condition, about the risks of, if they continue contact sport, but about the benefits continued non-contact activity. Even if it's just regular physical exercise or a non-contact sport, the benefits of activity are overwhelming. So going back to youth patients and pediatric patients, there's this concept called the right to an open future. And it emphasizes that adolescents should be protected from having significant life choices, such as participation in contact sports, determined by others before they have the maturity to make informed decisions for themselves. And you can see where that applies in other aspects of healthcare as well. So in concussion care, this principle underscores the importance of involving young athletes in discussions about their health and about their sports participation, ensuring they understand it at their level and the implications of their choices for their future well-being. So wrapping up, no one wants to experience concussions. No one certainly wants to have to end their career in a sport that they love due to concussions, but they do happen. So we know that roughly 10 to 30% of all injuries in high school and college sports are concussions. And in some cases, the recovery doesn't go as planned, and the risk of continuing that contact sport outweigh the benefits of continuing that sport. So this is not a decision to be made lightly. To play or not to play in higher risk complicated cases is a tricky conversation. So you want to be in direct contact with a concussion literate provider, a concussion literate care team. It's essential. So one of the easiest way to filter who's legit or not, who has a good understanding of concussion or not, is to first search through the Complete Concussions database. Finding a Complete Concussions clinic in your area just ensures a baseline level of competence. And please remember that physical activity, even non-contact sports, should absolutely be pursued if retirement from contact sports is eventually recommended or decided upon. The benefits of exercise, particularly dynamic social exercise like sports, cannot be overstated. While the transition to football or ice hockey to golf might feel difficult, the benefit of continued physical activity, social engagement, and play will serve you well way into your future. So if that's as clear as mud, great. That's kind of where providers are at as well. It's a complex multi-person decision that needs to be based on symptoms, exam findings, academic career implications, health complications, financial implications, and more. The athlete, their partner, their spouse, their brother, their sister, their teachers, their moms, their dads, their doctors, everyone should be involved in the process. And no matter what happens, keep moving, exercising, and playing, even if that's non-contact sports. I appreciate you sticking around. If you enjoyed or learned something from this video, you might also enjoy or learn something from these as well. Until next time, I'm Dr. Mark. Thank you.